Hi, this is a great crowd. Thank you for coming. My name is Cliff Scheckman. I'm the executive editor of the Maine Sunday Telegram and the Portland Press Herald. When we began this project a year ago, more than a year ago, we had one central question. Who were these people who were dying at record numbers? Numbers so high that it blew away the numbers from previous public health crises. The AIDS epidemic in Maine at its height, I think it was 1992, saw 69 people succumb to that disease. Last year, the latest opioid death numbers released today, 376. To answer that question, we interviewed more than 100 families who lost a loved one. We learned a lot from these interviews. These were very difficult interviews, very difficult on the families, very difficult on our reporters and our photographers. We learned that women were particularly susceptible to this public health crisis. And while they sought treatment at the same rate as men, only a third of the beds were available for them. We learned that children were being pulled out of homes with drugs at record numbers, stressing the child welfare system in the state. We learned the lobster industry is overrun. Even though many in the industry may not want to admit it, is overrun with addiction. But more than anything else, we learned about the tremendous pain, the pain that ripped through families and communities. I know a little about this pain. I'm the father of a recovering heroin addict. A child that was loving and talented became a user, mean-spirited, almost died. The pain he endured and the pain he caused me and his mother at times was almost unbearable. Today, he is clean for 3 years, and I can say there's hope. He today is a loving, caring, considerate, productive, talented musician. There is hope if we frame the conversation properly. These 376 people who died in Maine were they disreputable lowlives whose personal behavior brought their pain onto themselves, as some people would have you believe? Or did they make a few mistakes and are fighting a disease? The experts will say it's a disease. The hope will be if this project reframes the conversation, such as the conversation we're going to have tonight, so that we could figure out the best way to prevent it and to treat opiate addiction. I'd like to introduce two people, but first I want to say, we are not a large paper, we're a small paper, and it was a remarkable effort on our part to have more than 50 people in our newsroom work on this project. It takes a lot of resources. Our publisher, Lisa DeSisto, I'd like her to stand up, supports this kind of journalism. And allows us to do this kind of important, life-changing work. The other person I want to name is the person who's going to be the moderator, Dieter Bradbury. Dieter is our deputy managing editor for news, and he was the project editor on this. And he spent a lot of time with a lot of families and a lot of reporters, and he did remarkable work. Dieter Bradbury is going to take it over right now.
Now, this is a great crowd. Thank you all for coming. It's really heartening to see so many people concerned about this issue. I want to echo what Cliff said. A big thank you to Lisa, our publisher, and to Cliff and to Steve Greenlee, our managing editor, for all the support that we got working on this project. There were many days when my fellow editors were saying, "Where are all the damn reporters?" Well, they're all working for Dieter, on this project. So I think we took the long view and really committed to putting a lot of effort and time into doing this story, which we think is really one of the most important stories facing our state. I'd like to introduce the people who are going to come up here tonight and talk to you and take your questions. If you folks could come up. First, Eric Russell. Eric was the lead reporter on this project. He wrote, I think, 5 or 6 maybe of the major stories that we did in this series. Tremendous stories, really powerful, really moving work on his part. And he's a big part of this project and its impact. Brianna Sukup. Brianna was the principal photographer here for us. She carries a camera, but I think she took a lot of these pictures with her heart. And I'm going to have her talk a little bit later about how she did that. So such incredible work. And also, please welcome Nikki Curtis. Nikki is Portland. Nikki is I think you're a Portland resident. I'm sorry if you are. Yes, thank you. Nikki's a woman who's in recovery long term, and she's also the manager and founder of Monarch House, which is a sober house for women in Portland. And she'll tell us about that. Also, Chris Hafford is here with us. Chris lives in Portland, and he is the brother of Bobby Joe Hafford. Bobby Joe died of an overdose in October of 2015. Chris is going to talk to us about his brother a little bit. And we will have another person here, Eric Harum. Eric is an addiction expert. He's a treatment expert, and he's formerly the director of an addiction treatment center in the Midcoast Hospital area in Brunswick. He's also a consultant now nationally, and he had a little bit of an overlapping commitment. He's on the phone on a conference call with hospitals in a bunch of different time zones talking about setting up new treatment programs, and so that's a good thing, so we're going to forgive him for being a little bit late. And he'll make a dramatic entrance a little bit later. I just want to say, most importantly for me, and I think all of us who worked on this at the paper, we owe our biggest thank you to the families who agreed to talk to us and were so open about their experiences. It's, I think it's unimaginably difficult to be forthright and open about a subject which people do so much judging about, and where there's still, unfortunately, so much stigma attached to having an addiction to drugs. There's not a lot of upside to going so public about this experience and about the impacts and the pain and the grief that it can cause. So we were really immensely grateful to the families who agreed to speak to us and opened the door for us to do this work. So thank you. So I think I'd like to put Chris on the spot maybe first. Chris, if you could maybe tell us a little bit about Bobby Joe, his life, and maybe a little bit about your family's sort of decision to meet with our reporters and talk about him.
Firstly, I'd like to say thank you to the Press Herald for doing the article. Incredibly important. Thank you for everybody for coming. It wasn't easy to do the interviews. It's not been easy to see the articles come out. You know, it brings up a lot of emotions that aren't always on the forefront, kind of reliving some of the stuff that's happened. You know, it would have been easier for me, easier for my mother to not participate in this and you know, ignore kind of what had happened to us a year and a half ago when we lost our brother, but ignoring things doesn't ever fix them, right? I think you've alluded to the stigma that exists around addiction, and fighting that and working to show that these are people, they have stories, they have loved ones, is a very important step for all of us to be involved with. my brother was a great person. He was funny. There's a few people in this room here that knew him. Everybody that knew him loved my brother. It wasn't a person that would have anything bad to say about him. For him to be judged on the way that he left the world would be a tragedy, I think. And the difficulty in being part of this process is rewarded by the fact that I know that his story is out there, that people get to read about who he was beyond the way that he died. And I'm so thankful to read all the stories that you guys have put out there. These people aren't just criminals, and we can't police this away. We need to treat it as a health issue. And one of the biggest first steps to doing that is to fight the stigma that exists and fight this narrative that these are just bad people that need to be locked away. So I'm grateful for what you've done, for everybody involved.
Thank you.
Thank you.
Thank you. Eric, can you talk a little bit about how you went about tackling this project and working with people like Chris and families, and how they played a role in bringing this project to where it was, and how they contributed to the work that you did, and sort of your work process tackling something like this. How'd you go about this?
There's an old journalism cliche about giving voice to the voiceless, and I think this project really, is that better? And this project really kind of, I think, all right, I'll take it off. So I think this story was happening. People were talking about this in every community, but it wasn't really, public in an effective way. I think it really started a couple of years ago. We started to see some obituaries from family members. They started to be very candid about how their loved one died. And it seemed like, they wanted their voice out there. They wanted this out there, but it was also really hard for them. I mean, as Chris alluded to, as Dieter talked about, the stigma and the shame is very strong. So when we first, reached out to family members, we weren't sure what we were going to get. We didn't know what the response would be, but more and more people kept coming back to us saying, yes, I'd love to talk about my loved one. I'd love to share this story. I'd love to, present them as more than just this label of addict. And one thing that strikes me, we talked to 100 families, we profiled 60 people, but that really only represents a fraction of the number of people who actually died just last year, let alone the last several years. So all of these stories were coming in from family members of loved ones who died. We started to see some similarities and some patterns, some things we knew that we could confirm, and other things we didn't know. From that, I started to, devise some questions that we needed to ask and bring in some experts. And so I just started to talking to as many people as I could, people who were in recovery, people who were in treatment, people who were experts, people out of state, people in state. And everybody, I was really struck by how willing people were to talk about this. I think that's probably been the biggest barrier to tackling this crisis, is this sort of fear of putting yourself out there or putting your family member out there. But I think it speaks to the power of this project that so many people were willing to do that. From there, it was easy enough to write these stories because, people were so gracious and so open with the details. It wasn't difficult in that sense. It was difficult because it was heartbreaking. I mean, there's so many people who, they're so young. These people were so young, 20s and 30s, and, they deserved a longer life than what they had. So those kinds of things stick with me. But I think people are here, people are talking about it. I think that's the best you can hope for any story, any project that you work on as a journalist.
Sorry. Brianna? So Eric comes in with a notebook and a pen, and he talks to people for hours, and he takes notes, and he gets to put together, from those notes and those conversations and interviews a story. You have a camera.
Yeah.
How do you approach a project like this and get those kinds of images?
You know, I did a couple different things. I see some people I took photos of here, and it's really great. So some of the photos I took for this went along with the story, right? So it was a little bit easier, like the whole like narrative was there. So for those sort of things, I feel like I'm coming in and I'm just trying to show like another human element, you know, like who are these people who have been affected by it, whether it's Shannon who was in recovery or the Bakers, you know, who are taking care of their granddaughter. It's like, these are the faces, you know, behind the numbers. And I mean, I think the stories do that obviously too, but I don't know, I feel like something about a photo just like can really show you who a person is. And then I did a portrait series on families and mostly parents who have lost someone. And, you know, that was a little harder because it, you know, it was me coming and just being like, can I take your photo? And I mean, the photo taking was pretty short. It was the talking, you know, and hearing the story. And, you know, I was like, I'm sorry, I have to ask you to tell this again, you know, to me, because I feel like I can't really take the photo without knowing the story, you know? And so they not only had to tell a reporter everything, they had to sit and tell me everything. But it seemed like for most people, they wanted to talk about it, you know? And, you know, I'm one more person who's going to remember their kid for who their kid was. And I don't know, I sort of just let people sit there, and I don't give a lot of direction. And I'm just trying to kind of get the raw emotion after, you know, you just talked about someone that you lost. So it's kind of what I tried to do.
Thanks.
Yeah.
Nikki, thanks for being here. Can you tell us a little bit about your experience in recovery and how that led you to setting up Monarch House and the place you're trying to create for women?
I came into recovery almost 5 years ago. I'm in long-term recovery, and I worked at Portland Recovery Community Center I went there as a participant and attendant, and then I worked there after about a year in my recovery. I was able to do that. And a big portion of the people who come to the recovery center are people who are in sober living. Like, that's a good portion of, you know, who comes into the recovery center. I saw what was going on and how they were being more successful and how they were supported in learning how to live with this disease and making better decisions and changing behaviors and the views around that. And what I did see was there was almost no sober living for women. And I was participating in the story that they did on for women in this series. And, you know, there's like 10 houses for women for sober living. Just to give you an idea, sober living is usually a fairly structured housing, community housing, where everybody's living together, you know, men with the men, women with the women. There's not co-ed. They have rules and curfew and random urine screenings to make sure that they're doing what they're supposed to be doing to kind of help give accountability. And that has been a really great support for people who have just gotten out of treatment, who are coming out of the detox, or and who want recovery to support what they're doing. So when I was approached about this, I was asked to take on this sober living home, and at first I wasn't sure, but I had been watching what had been working in some and what hadn't been working in others, and I decided at that point that I wanted to do this, that I want to help people live. I came into recovery at 40 years old, and I had a lot of old behaviors, a lot of old patterns and you know, bad decisions and decision making that I needed to fix. So I wanted to create an atmosphere where women could come in and be human and learn how to live and be better mothers, better sisters, daughters, you know, family members, but learn how to be better to themselves and to each other. And I've been in this for in the sober living side of it for about a year, and I've grown in my own recovery because of the work that I've been doing with them. I've actually learned that I don't have to be perfect, that I'm human, I make mistakes, that I no longer have to use over that I no longer have to drink over that, and you know, that it's okay, and that I'm not alone. I loved being part of this series. I loved that we could have a voice in, you know, in what we're doing in that, you know, in that attempt at getting better together, you know, and the women loved being part of it and telling their stories. Like you said that about the stories. So I was really grateful for that in my own recovery.
Thanks.
Thank you.
Does anybody have anything they want? If anything they want to add? If not, I'm going to open the mics up to questions from the audience. Do we have more mics, or how are we going to handle this?
I've got one back here, so I can run the aisles.
Okay. Yeah.
I actually prepared something that I'd like to read, because for over about a month and a half since you prepared this series, I actually wrote something because I tried to call most of you, but nobody ever returned my call. Okay? So I don't have any glasses, so I'm going to ask my boyfriend to read this for me. Hi, sweetheart. His name is Shane Brooks. He's been around here for 47 years. His family owns a company in mid-Maine named Houston Brooks Auctioneers. And would you mind reading it, love? My name is Angela Einstein. I'm an alcoholic. I've been in recovery for over 22 years. I love the program of Alcoholics Anonymous. Yeah, you can. Do you have glasses? Does anybody have any readers? Oh, thanks, sweetie. Okay. He'll read better than me, you guys, because I'm wicked nervous. Like I said, I would prefer to just have talked to someone, but since nobody returned my call, and Cliff Shilsman, whatever his name is, his voicemail has been full for about a month now. Here you go, sweetheart.
Okay.
Not much of a get out.
Again, my name is Shane Brooks, and at the top of this, the thing she has prepared is the definition of addiction: a physical or psychological need for a habit-forming substance, such as a drug or alcohol, and physical addiction. The body adapts to the substance being used and gradually requires increased amounts to produce the effects originally produced by smaller doses. See more at withdrawal. Number 2, a habitual or compulsive involvement in an activity such as gambling. Okay, here we go. I copied and pasted the definition of addiction from dictionary.com. The media is making addiction new by changing its mask to create hysteria and to sell newspapers. The Portland Press-Herald special report, Lost, Heroin's Killer Grip on Maine's People, is a recent 10-part story on heroin that is killing Maine's addicted. Vietnam ended 42 years ago, and heroin was the opiate that our soldiers came home addicted to. Why is the same problem being recycled in a new form? Have we not listened to Graham Nash and his clairvoyant message in his song, Teach Your Children Well? I have had almost every illicit drug in my veins, up my nose and down my throat. Also, I have cheered with every socially accepted type of alcohol that our society promotes and encourages us to drink with daily doses of in-your-face advertising. Even children's movies have references to blatant alcohol intoxication. I had to quit each of those liquids too, one by one, along my road to recovery. Today, I stand proud and tall with recovery of 20-plus years alcohol-free. I do not point fingers. I am an addict, free of all illicit and addictive drugs, including my body's most addictive drug, alcohol. I hold on to 24 hours, one day at a time, and I love and admire every single person who walks along with me. I stay on the correct path because my recovery comes first. Through the years, I have been taught to listen first to my therapist and doctor, who have been my conscience through all of my recovery. Although I have been guided by many others and am very thankful, I would not have made it without the guidance of Alcoholics Anonymous, family, friends, perfect strangers, and even a few celebrities along the way who have literally saved my life. The problem now lies with the media and the BS that they feed to the public about addiction and recovery. Young children are losing their parents daily in Maine because of the irresponsibility of adults and the media placing blame in the wrong areas. Each addict needs to take responsibility for their own actions, one day at a time, and sometimes one moment at a time. The cycle of addiction needs to stop with the generation holding the drink in their hands now. When America talks about drugs, there is no mention of the real gateway drug. It is alcohol, folks, and guess what? It has a total and unwavering support of our government. After all, what is more fun than dumping poison down your throat and letting it make all the worst decisions of your life, including doing any drug on the planet Earth that decides it would like you to do, period. Angela Einstein.
I'm on Facebook.
Thank you.
Thank you, Angela and Shane. Someone else have a question?
Hi, my name is Kitsy Winthrop, and I'm a retired parish minister, Unitarian Universalist, and also a hospice chaplain. And one of the things I'm always aware of, whether it is in the field of addiction of any sort, or just in our daily living, even if we don't have an addiction, is the real lack of the spiritual dimension of our lives. I'm not talking about religiosity. I'm not talking about belonging to a church or a mosque or a synagogue or anything else. But it is so true that our culture has been so desacralized. We are so disconnected from this planet. We are so disconnected from other species and from each other and from our own inner being. So in addition to all of the wonderful therapies and the medical assistance, I would like to say that we need to bring the whole area of addiction, whatever form it takes, not just from left brain solving, but also for right brain being, which is learning, teaching our children at the earliest age, and as adults learning to reconnect with life. I am somebody, I say to people, I've never had an alcohol beverage in my life because I don't like it. And I just think that it is, nor have I ever had a drug. And yet I stand in no judgment of those who do, because I know what it feels like to feel radically disconnected from what is a pervasive giving of this universe and relationships that we need to foster in care. So I would just urge us to add this sacred dimension to the medical, to the psychological, to the intellectual. It's the fourth quadrant, and in this culture, it gets very little attention. And it is, to me, at the core of everything that matters, and it's at the core of what I think is the root cause of most, maybe not all, addictions. Thank you.
Thank you.
Thank you. My name's Larissa Sellers, Shift. I'm just curious about what happens now. Two things, I guess. I'm curious about the resources that went into the series. I appreciate the publisher's support of the series, but I'm also curious about both the publisher and the owner's support of the series going forward. Where do you go from here? What happens with what you've done? Do you come back? What's the follow-up? How do you stay connected? You've done this remarkable thing, but this crisis isn't stopping. And what's your commitment as a news organization to continue?
That's a good question. Thank you. We've written a lot about this crisis outside of this particular series, and we'll continue to do that. I mean, there's a story we're publishing tomorrow related to opioids, and we're planning some others. I don't think you'll see us do a project on this scale again really soon, because it was an enormous investment of people and time. So we won't be producing another 10-part series really soon, but we are committed to covering this. It's one of the major issues facing the state of Maine. I mean, so many people are affected so deeply by this, and it's not going to go away anytime soon. In fact, it might get worse before it gets better. So we have an obligation, it's our job to stay focused on this and pay attention to it. And as much as possible, I think we will continue to try to humanize it, and not get caught up exclusively in numbers and data and policy, because those things are important, but what makes it real and what made this series real are the human beings that are involved.
If I can just build on your answer, Dieter. I'm Lisa DeSisto, I'm the publisher. And of course, we're going to continue to report on this in the newspaper every day. The series lives on our website. So what's been great about it is we've been able to track how people are reading it. And I think almost in every state across the country, we've had people logging on to read the series. We're obviously convening forums like this to continue the discussion. And we are also going to reprint the series all together in a 32-page section and make that available to local institutions that would have an interest in sharing it with their members or staff. We got a ton, probably hundreds of emails from people, and they came in from all different parts in the organization, whether they were direct to Cliff or to Dieter or anyone working on the project. And one of the ones that really hit me the most was that we got from someone who runs a correctional institution in York County, who said that the inmates were all reading the series religiously day after day. And to make that kind of an impact on people who are incarcerated, I think is just something that we didn't even consider. So to make copies of the series available to more people that want to read it is part of what we're going to do. We do about one major project like this a year. In the time that I've been here, I can't recall anything that we've done to this magnitude. It does take a ton of resources. There is not a financial payback for our institution to do this, but it's part of our commitment, our public service commitment to serve our readers and the community. So we will continue to report on the story. The other thing that I thought was really kind of amazing was, as Dieter said, so many people in our organization, all the reporters worked on this. Some of the profiles were some of the best profiles, although they were all well done, were written by our sports reporters. Meredith Goat, who's our food writer, wrote some of them. So it really did touch everyone in the organization, just not the news staff.
I want to jump in just a second. Eric Harum has joined us. I spoke about Eric earlier. He's the person who knows very much about the subject of treatment, and I'm sure he'd be more than happy to respond if folks have questions on that subject.
Thank you. First of all, I want to thank you for putting the series on the other side of the paywall so we can all read it. It's really good to be able to log into the paper and actually read the entire series word for word. One of the things that I would assume happens when you're doing something in this depth over this long period of time is that many other ideas come to you, many other storylines, many other hooks, many other paths that you think you might like to follow. I'm curious about what some of those might be. One of the ones that occurs to me is really looking at the medical world and their responsibility in this. You touch on that in the article. But I'd like to know what's really being done, how prescribing is being handled differently, how pain management is being handled differently, and what kind of local, state, and national efforts are really being made to make sure that, you know, this is managed more humanely and reasonably and not just for the benefit of the drug companies.
That's a good question. The whole question of prescriptions and painkillers is a huge one. I think one thing we learned from this series is that 70 to 80% of first-time heroin users started with a prescription painkiller and went from there. And the role of prescription painkillers in this epidemic is just enormous. And a lot has been written about that. We have written quite a bit about that subject. We didn't focus a lot on it in this series because we had a different goal with this series, but it's something that we're going to be paying attention to. The state of Maine has tightened up on prescribing practices so that it's going to be much more tightly controlled. If you're a doctor, you will not be able to write prescriptions as freely as you could for opioids. That is creating a whole other sort of problem that we are learning about, in that there are about 14,000 people in Maine who have been on long-term opioid prescriptions for chronic pain. I think there are legitimate medical questions about whether opioids are even effective for chronic pain relief, but clearly people are taking them for that purpose, and there's a whole group of people who are looking at having their dosages reduced as a result of new Maine laws. We've been hearing from those people. They're alarmed about how they're going to function in their lives going forward without access to these opioids, and that's a problem that the state is going to have to come to grips with. I'm wondering whether maybe, Eric, you might want to speak a little bit, since we're sort of getting into the topic of medication on that subject.
Sure. I had the, I guess, privilege, although it was a daunting one all last year, to co-chair a statewide task force looking at the treatment of opiate addiction, particularly around the issues of dependence, misuse, and overdose. These are sort of the three primary ways in public health we think about this problem. Folks are dying from overdoses regardless of which three of those buckets their relationship with an opiate is, right? And I think that's important, and so that we're not only thinking about overdoses related to someone with an addiction disorder. There are lots of people who are patients who are taking medication as prescribed, who have inadvertently overdosed, or individuals who, without a prescription, misused a substance. They were naive and something bad happened. And so it's really all three of these populations that our strategies have to think about. So that being said, as you're aware, very little has happened over the last decade to expand access to not just medication-assisted treatment, but really any treatment in the state of Maine. Whether that be integrating it within the general medical community or developing it as a freestanding specialized service. One of the things I asked for on the task force was some measures that are readily available at the state. How much treatment do you buy in each region of the state? That's a denominator, the bottom of the fraction, and the top of the fraction is how much of that is for MAT, right? Specifically designed treatment for opioid addiction. And you would start to see very, very, very small ratios, region to region to region. Operating a treatment center in the city of Brunswick and Damariscotta for the past 11 years, it's one of the few communities in the state that has put together 8 quarters in a row of no overdose deaths. There is a hugely strong correlation mathematically between access to treatment and a community's mortality. The more treatment that is accessible, the fewer people will die. That's a given. We've been able to quantify that as much as that when a person receives access to appropriate, relevant treatment, their overdose risk drops 50% in that moment. Okay? As a behavioral health provider for the last 30 years, I have almost never been equipped with a system, a tool, a design, a medication, an intervention that has the ability to make such a staggering positive impact. Okay. That being the case, you have to wonder what took so long, right? And the good news is that that is now happening. There is development from the State Department being willing to accept federal funding to help expand these services, where for the past 8 years there has been a blatant refusal to accept those funds. There's at least 3 health systems in the state of Maine that I'm consulting with right now on 12 to 18 month long projects to embed medication-assisted therapy in all of their regions and locations, and between those customers we'd be looking at close to 2,000 new MAT slots. None of those have been earmarked financially, none of those have been supported by the state. This is grassroots development because it's time and it's the right thing to do. Financing of those things will need to be supported because, as you know, about 40% of the individuals in the healthcare system do not have insurance of any kind.
If I could expand, Peter. I just want to expand on that a little bit, and Eric probably would echo this. You know, one of the things I found in reporting this project and speaking to people in recovery and in treatment, medication-assisted treatment, there's a real disconnect. There's a real fracture. And it's kind of hindering progress, I think. There's still a big divide between people who, like Eric, and like most medically driven, scientifically driven people, that medication like methadone and Suboxone, which, I mean, they have their own stigmas, I think, but it's absolutely proven to both save lives and to get people on a path to recovery. But there's still a big segment of the population of the recovery community that doesn't believe that it's a valid form of treatment. And so I don't know if you want to expand on that a little bit more, but as I kept reporting about this, it kept coming up. And even people who are in recovery, even people who are in a Suboxone program or a methadone program and were doing great, and they had their life, and they worked, and they were taking care of their kids, and they weren't overdosing, they still had this feeling and the shame that I'm still on a substance. And they just couldn't quite get past that. And I think that's part of framing this conversation too. This, just as we label people addicts, I think, they do it to themselves too. And they feel like, if I'm taking this substance, I'm never gonna be able to be clean. And even though, we have all this research and all this data that says these medications work, they give people their lives back. I don't know if you want to touch on that a little bit, Eric.
I can do that by briefly telling a story. When I was running the Addiction Resource Center in Brunswick, we had a pretty high volume of young pregnant women that came through for treatment. Sometimes more than once, with first child, second child, third child. And there's this phenomenon that occurs where these young women were coming back into treatment, having seen them doing well in the past, and I would say, help me understand what brought you back. Both the good things, so what was inviting and not frightening so that you could come back and get help, but also what happened, right? Because when I last saw you, you were doing very well. And particularly with young moms, or moms in general, there's so much stigma associated with your role as a parent. No one aspires to become addicted, and no one aspires to have a chronic illness or to have to take medication to be a part of a maintenance program. No one woke up one day and said, I'd really like one of those relapsing and remitting conditions. Things have gotten boring, right? And so when you find yourself in that situation, it's absolutely shocking. And it takes a long time, and a part of the relapse and remit is the person's own self-perception about their condition, right? And so this young mom said, well, I quit taking my Suboxone. The baby came, everything was great, and I just started getting a lot of pressure from my family. You know, if you were really a good mom, would you need that medicine? If parenting your child was enough for you, would you really need that medication? Now, those are, I think, pretty well-intended prompts from family members. But for the person with the chronic illness who needs the medication for maintenance, right, it just seeped in over time. You know, maybe I would be a better mom. Maybe it would all be enough if, right? And eventually gave in to that pressure and that stigma. And of course relapsed again and came back to treatment.
Thank you. More questions?
All right, I'm going to stay sitting down because I'm a little nervous. I'm going to ask my question first and then tell you a little bit about my story. I'm wondering, as a parent, what is out there that I can help to get treatment for people? What is there that we as a group, as parents, can come together and try to influence Governor LePage to take these funds or whatever? 10 years ago, my daughter got pregnant, and she wasn't on drugs, or so she says, but her boyfriend was. When my granddaughter was 3 months old, he died of a drug overdose. I have been raising my granddaughter since, not quite what I expected to do when I was 50 years old. And unknown to me, now I'll step back a minute. My husband and I have been married for 31 years. Neither one of us have ever drank. We've never smoked. We spent all our time with our children. We did all the things that parenting books tell you that you're supposed to do. My son, from the age of 8, had extreme anxiety. He had agoraphobia at one point. Luckily, it got better. When he got mixed up with my daughter's boyfriend, me being so naive, had no idea he was doing drugs. He was probably 12 or 13 years old. And he's now a recovering drug addict. It's hard for me to say, but it's the truth. It's what we live with every day right now. You know, I hope he's gonna survive. There used to be a point in time every day, phone would ring. I was afraid he was gonna be dead. But we have insurance. We have great insurance, but there's no doctor. There's nobody that can take us. We've been with Martin's Point for 35 years. We have been on their waiting list for 2.5 years for him to get help. As a mom that pushes, I, at one point, 3 years ago, found him a doctor, got Suboxone. My son didn't really dare to say much. They didn't send him to counseling. And he survived. He was doing well. But that doctor believed that after 1 year, you were done. And so his 1 year came up, and he was done. And back into the pills he went. We couldn't find another doctor. Me, as a law-abiding citizen, was out on the street trying to buy him Suboxone, trying to buy him pills if I couldn't find Suboxone, afraid that I was going to be pulled over by the police and they would find that stuff on me. But my son had to work. He wanted to work. And so we bought this stuff illegally. We spent hundreds of dollars a week. And then they tightened up the laws on prescription. And Suboxone was even harder to find. And the price went up and up. We were paying $50 for one strip, and every single day, I work full time, I spent every day calling any place I could find to get a strip of Suboxone so he could make it through the day. And we couldn't find any more. I was desperate. I didn't know what to do. I was calling everywhere. It was awful. I was afraid my son was going to die every day. I happened to be driving on Forest Avenue, which is where I worked, and I think the place was called Portland Recovery Center. And I pulled into that place. I drove by, and I said, oh my God, I'm going back there. Maybe they can help me. And I went in, and I talked to them and told them my story. And they called at least a dozen places. And everybody was full. There was no one. They didn't care if we had insurance. They didn't care that we could pay. There was no place. They did finally find us one place, which I'm so thankful for. My son's been going there about a year. And they don't take insurance, though. They take main care, but they don't take insurance, so we have to pay. He pays. He works a full-time job. So right now, he's spending $200 a week to go to counseling, to get his Suboxone, and he makes $250 a week. He has $50 left. It's not even enough money to put in his gas tank. But he's doing it, and I'm proud of him, and I help him. It puts us in a big bind financially, taking care of my granddaughter, taking care, it's not his child, taking care of him, helping him get along, because, people say, oh, use tough love, tell him too bad. Well, he would probably be dead if I did that. And, so I keep hearing about main care is not supported, but even if you have insurance, it doesn't matter. You can't find anything. And I will say that the one happy ending to the story is the counseling is a huge difference. That doctor he went to that was just Suboxone, the minute they stopped his Suboxone, he was nowheres. And when my son first had to go, this is sort of funny, when he first was made to go to counseling, he said, I don't want to go there. They're all drug addicts. They're not like me. And I'm like, really? Matt? You are a drug addict. And now, he's like, hey, I've met some nice people there. Their moms, their dads, they have kids, they have pregnant girlfriends. And I give them a ride because they have no way to get there, and they're struggling, and they're just like me. And so it was really eye-opening to him and eye-opening to me. But I think that counseling part makes a huge difference. But as a parent, I feel like, how do I reach out to these people? Even reading your series, which I did not want to miss, I'm reading comments, and yeah, half of them are supportive of what you're saying, and then the other half are like, nah, they're just a bunch of losers, they're criminals, they're this, and I'm like, how can you read these stories and say that? I guess that's it.
I think that this room today is one step. The story was one step. There might have been a lot of comments on that story that were negative. There's fewer comments after that story was published. Those numbers are slowly changing. Changing the perception, the stigma is a process. It takes time. My brother went through religious-based treatment. He couldn't afford it, and it wasn't really the right treatment for him anyway. What he needed was a therapeutic, health-based solution to an ingrained problem within himself. He never got that. He spent time in the criminal justice system. That didn't provide him the service that he needed, didn't give him the help that he needed. In this process of changing the stigma so that we as a society can demand that the political structure makes the changes that we need, this conversation right here is a huge step. We can all leave here and say, what's the next step? At least we know what we're going to demand of our leaders. We're going to demand that they provide health-based resources for these people. So I'd say that's my opinion.
Thank you for sharing your story. I was struck listening to what you were saying. It was so similar to what we had heard from many, many people, and barriers to treatment. And it's interesting, we often talk about barriers for people who are uninsured, who don't have the ability to pay, but it's clearly there are barriers for people who do have the ability to pay. I mean, things are starting to change. There are more doctors that are willing and able to provide Suboxone than ever before, but these barriers aren't going away overnight, right? I mean, they're still there. So I think you asked, what you can do. I think you keep telling people, and if you, even if it's one person at a time, then you change one mind. You know what I mean? Like, you're always gonna have people who think they know what addiction is or who is affected by this particular disease, but they don't. And so if you got an opportunity to educate your neighbor or coworker, take it. Take it.
Thank you for your comments. If I could add one thing, in working on this series, I've thought about, okay, what could one person do that could be a little bit radical? And I think the one thing you could do would be the next time you go to your doctor, your primary care physician, ask him or her, so do you provide Suboxone? Do you treat any people with addiction? And see what the answer is and pursue it a little bit. Because your doctor has all kinds of time to talk to you, right? Because I think the figure we've seen is 5% of the primary care physicians in Maine will write Suboxone prescriptions right now, which is hugely inadequate. And there are lots of reasons why physicians are reluctant to have that kind of a patient in their practice. There are all kinds of issues that come up. There are financial issues that come up with some doctors. But I think it would be a very enlightening and interesting conversation to have with your doctor someday, the next time you go in there.
You touched on something that I think is important, and what you asked was, what can we do? The theme here around access to treatment, particularly access to medication-assisted treatment, is not really a complicated public debate. We know it works, there's not enough of it, so we should have more of that. The discussion really isn't what flavor of treatment. Is residential treatment better than outpatient treatment, better than halfway houses, better than intensive outpatient, right? The fact of the matter is that you can embed and integrate medication-assisted therapy. It's one medicine, right? Just one medicine out of the many that are already prescribed into any and all of those different treatment environments, right? That's important because one of the ways we've avoided getting MAT services more globally available is we've thrown red herrings at it by saying, well, but you need a residential bed. You need an opiate bed. You need a flavor X, Y, or Z. And the reality is any of those treatments are effective, but if you can't calm down the person's utter withdrawal, preoccupation, and craving, it won't matter, right? And so that's a way to simplify the discussion. MAT can go anywhere, and that's important language. Second is you kind of picked up on a dirty secret about the architecture of state-funded treatment systems. They're really only designed to serve one population, folks with Medicaid. And that's it, right? There's small numbers of grant slots available, 2 or 3 a month. But if you have private insurance and find you can't get in, that's a bit shocking. And many, many, many people in Maine have had that same shock, right? I work, I have insurance, I have this health issue, and you have a service that I need, and you won't let me in because I have insurance and can pay you? Right, that's bizarre. So the other thing you could do is start making noise about, wouldn't it be great if the publicly funded treatment system could accommodate more than just one population? When I ran the ARC, they didn't take private insurance. The first year I was there, we paneled with everybody. And the thing that was able to occur is, even though I never got enough grant money to run the program and treat everyone that came through and needed it, by billing private insurance, which can pay at a higher rate, I actually extended the state's grant by another $500,000, right? And so this is a way that folks who run social service agencies can make sure that they're not at the whim of every government blip in funding. Right, is that these facilities are supposed to be available for everybody, and they're not. And that's something that we need to hear more people talking about.
Other questions? Yes.
Hello, I'm Priscilla Jenkins, and I have a comment on personal differences. My husband's a recovering alcoholic, and he just quit. And he says people can just quit. Well, some people can just quit. He always told me the reason I was overweight is you can't quit food cold turkey. You could cold turkey it for a while, but you got to go back. But it is a comfort to me. Food is a comfort. And I'm a cancer patient. I'm recovered. When my doctor and I were discussing the treatment, he said, you're going to need pain relief. And he said, but you're not an addictive personality, so he put me on hydrocodone. I could use as much as I wanted. I did use as much as I wanted and needed. And with some help from my family, at the end, I weaned off it, no problem. A lot of the other part of this that we aren't talking about is prevention. And I think a treatment in prevention is, we need more treatment in mental health, a lot more treatment in mental health. We need the access to young people and older people. We mentioned the younger people in the article, but there were 50s and 60s in there too. And stress, people go to substances to relieve stress. And if there aren't others, I do agree with the minister who spoke earlier that spirituality, a connection to nature, we know back to nature is good for a lot of us. Genetics predisposes us to be related to nature, but the options for people are wide or none. I'd love to know, our North Pond hermit managed 25 years away from people without drugs. But had he been with people, would he have gone to drugs? I'm wondering. But I think we need access for prevention in mental health areas as a very serious piece of this puzzle.
You brought up a good point. I think you asked, what are we going to do to follow up in the series? And I do think prevention is an area that we're likely to cover a little bit more intensely going forward. Prevention's it's a hard thing to write about. You can't humanize it in the same way that you can humanize treatment or certainly overdose deaths from family members and things like that. So it's a harder thing to write about. But we did a little bit of reporting on this for the series, and I think it will continue. But I think you're absolutely right. How do we? We've got this whole generation of people that are at risk of becoming addicted, but we've got this next generation coming up too. How do we stop them from using in the first place? A lot of people that I talk to who are in active recovery, who are in treatment for opioid addiction, a lot of them talked about using as an escape, right? Everybody kind of wants to get out of their own head sometimes, and they found this substance that allowed them to escape. I don't think if they thought that it would take over their lives, they would have made that decision. But I think it's not like people haven't been trying to escape or self-medicate or whatever term we want to use. But I do think that the woman brought up alcohol before. She's absolutely right. Alcohol, that people do it with that, and it's a socially acceptable thing. And we shouldn't overlook that that disease as well. But I think prevention. It used to be sort of this just say no, dare model, and I think it's a much more nuanced thing. What we know from people who become addicted is there's a genetic component, a really strong genetic component. There's also environmental factors. So if they're in a household of poverty, or if they're in a household of abuse, or other factors, they're much more likely to become addicted or to use in the first place. I think that's where preventative efforts are trying to reach. But that's hard. You're literally going into families and trying to give them support, and that's a big challenge in a state like Maine. So.
Yeah, I was thinking about Nikki, and I think it's important talking about mental health to realize that a lot of the people, not everyone, but especially for women, past trauma is a really, really a really, really big factor. And I don't know, I mean, I know that Nikki, you know a lot about this part, working with women, so I just think it's really important to like keep like someone's past in mind, because you don't always know their story and the things that they've gone through. So I just think it's really important too.
Past trauma in my story, I have a sexual abuse trauma that was from a really young age. And a lot of my escape was from the shame and guilt around that. Drugs actually saved my life. Alcohol started, and drugs like saved my life in a lot of ways, because without them, I don't think I would have been able to live with the inability to cope at such a young age with the feelings that I was having regarding the trauma that I had endured. So I have that starting point where without them, I probably wouldn't have made it. And at the end, it's the thing that's killing me. So it's like quite a cycle to have gone through and not have any control over. In the beginning, I liked it. I had that control over it. It did exactly what I wanted to. It numbed out the feelings and the overwhelmingness of life, you know. And at the end, I was so overwhelmed by my inability to control it that I wanted to die. So it's a really, really twisted way thinking that it creates. And I know from my own experience, but also from like working in the field now and dealing with other people and having that same commonality is like, you know, my brain has changed a lot because of the use that I've had, you know, that I've participated in. So the women that I work with, we talk a lot about the trauma and the shame. And I love what the woman says, like, it needs to be talked about, like Chris said too, like we have to keep having these conversations because my inability to ask for help is the thing that kept me out. It wasn't even that help wasn't available, that was the next step and the next barrier I had, but the first barrier was me. And that was because of the shame and guilt that I carried for years and an inability to say, hey, I'm in trouble and I need help. Whether as a woman or a man, I mean, both sides have that. But I had all these expectations. I was a mom, I was supposed to have this role and it was supposed to look this way, and I didn't fit that mold. You might see it look that way, but inside I didn't fit the mold. So it really was a struggle to ask for help, that initial stopping point. And it was almost, you know, it was the guilt of not being the mom I was supposed to be, or the daughter I was supposed to be, or the sister that got me to finally be desperate enough to ask for that. So I've done a lot of trauma work. I'm grateful. I can actually stand in gratitude today of the things that have happened because I'm able to use them to help others. And part of that actually, you know, you said prevention. A lot of that is talking to the youth, but from people who have had the experience and who have an ability to connect to youth at a younger age and be really open about the discussion. I have 2 girls actually from my house that are going to a middle school called. They know about addiction. They asked for some people who had experience with addiction because they didn't want to look it up on the internet. I couldn't believe it. I'm like, middle school doesn't want to look it up on the internet. I'm like, all right, we're in. But it was really cool. So we're, you know, the girls in my house have an opportunity to give back, and that's going to hopefully be part of that prevention, to know that initial inability to feel comfortable in myself and to escape from myself or to have coping skills, like hopefully they'll see that there are ways and that people, you know, that they can do that. So.
Thanks, Nick.
Hi, my name is Catherine Roulard. I'm with the Maine Health Access Foundation, and we've recently moved into the addiction care space, so the timing of your series, personally, as I've been trying to kind of get up to speed on everything, was fabulous, and I think you did a great job talking about the stigma from the standpoint of people struggling with addiction and in recovery. And 2 observations that I had reading were, and we've talked a little bit around it tonight, is around the stigma in the medical community. So on the one hand, there's this, I think, this very real, perhaps blame, anger, feelings, you know, that you caused the problem. And I can't begin to appreciate any of those feelings, but I understand that they're very real. But then that can also be a real barrier for providers participating in treatment, because it's, it's sort of this, well, I caused the problem and now I have to fix the problem by prescribing more medication. So I think I was thinking about the stigma in the provider community, and that's a real barrier that perhaps could be talked about. And then the other observation I had, and I think it was also highlighted this evening, is we all sort of look to the paper and say, well, what are you going to do next? And you have limited resources, and I think it raises the question about what is your role, and where do you kind of have to hand it off to others and say our role is to kind of put out the information. So maybe also, again, with all of your many resources and time, right? Just sort of acknowledging, even in an op-ed or a, kind of, here's the handoff, we put this out here, here's a call to action, or sort of here's what you can do. But those are just two of my observations. But thanks for all your work.
Thank you.
Good evening. I wanted to focus just for a minute on really the counseling, the behavioral health treatment, because in some ways the medical side of this is a little more concrete, at least than the counseling end of things. And it doesn't seem like we're talking very much at all about beyond the quantity of addiction treatment and counseling that's required, facing the issue of quality. Because I think there are vast differences in therapeutic capability and quality. So part of it is matching the right form of treatment to the individual's circumstance so that it's a good match. And the rest of it is really about the quality of the therapist or the counselor. And I think I'm a social worker myself. I've periodically over the course of my life have been involved in counseling, as I would guess that a lot of people in this room have been. And my own experience with things that are far less critical than what we're talking about tonight is that there's huge variability in the quality of counseling that is out there. So just because you hang up your shingle doesn't mean you're a good counselor, or the match of the counselor to the individual or the issues that are being dealt with is not good. So I guess, to Eric and others, we keep talking in the state about the need to substantially expand counseling resources. But again, there's almost no discussion about the quality of those resources and how, even if there were the finances to support it, how would we go about building a capacity in this state to provide not just the quantity, but the quality of really excellent behavioral health care that just isn't there in the quantity that we need it to be.
Two things that immediately come to mind. Nothing like a parent who's lost a child to get things moving. A gentleman that I've had the privilege of working with on a number of expansion projects for treatment, particularly medication-assisted treatment in other states, is named Tom McClellan. He's a former deputy director for our National Office of Drug Control Policy and runs really the premier addiction research facility in the country called TRI, which is in Philadelphia. And he also lost his son to a heroin overdose 5 or 6 years ago. And so had occasion to be at the head of the treatment pyramid in the nation and be confronted with the same questions you have. Where do I send my son for treatment? And how do I know it's any good? And he didn't have answers to those questions, and he really is where the buck stopped. He's done a lot of interviews on the radio, national publications. Thomas McClellan would encourage you to pull up some of his stuff and review it. One of the things that we should see go live nationally that he's really a big catalyst behind is modeling behavioral health treatment like the Consumer Reports, right? So there are qualities of good behavioral health treatment, of good counseling, of good therapy. We know what they are, right? They're very seldom, a consumer index of green circles to red circles to let you know you're getting a lemon or not, right? Or you're getting a really good deal. That's coming. And the one thing you can do is really find out as much as you can about that and tell everyone about it, especially your legislators. Healthcare is evolving into a much more transparent industry. Behavioral health is not far behind that because the questions you're asking. The state of Maine does have some performance indicators that they use with their contracted providers. Time from first call for help to when you get in. Were you offered a combination of medication and therapy? And then what kinds of therapy were you provided? Was it cognitive behavioral? Was it talk therapy? Were you guys just talking about the Red Sox, right? In an order of effectiveness. And so the more you're aware that those things are burgeoning nationally and in the state, the more you can be vocal about it and push. I agree with you. Our industry needs those standards and needs those publications, and they will be very good things. And I suspect the field will initially be somewhat recalcitrant and resistant, and will come along anyway.
Does anyone else have a question? Yep.
Thank you. My name is Jesse Harvey. I'm a person in long-term recovery, and I'm the chapter lead of Young People in Recovery Portland. Thank you to Portland Press Herald staff and to all participants that have made this a possibility. I have a question, but first maybe a little suggestion of sorts. The recovery community in Portland and other parts of Maine is pretty amazing, really, and pretty robust. And that might be an excellent, follow-up, a mini-part series on recovery, showing the other side of substance use disorder, on recovery supports, on advocacy, and what people can really do to sort of advocate for change at the local, state, and federal levels. The question I have might be really for everybody, but specifically Eric and Chris, is where the disconnect is in that people are asking for recovery. They're asking for, at the state and local levels, they're asking for treatment, MAT, even things like as radical, as supervised injection sites. Where is the disconnect that you guys see that there's also the demand for, for the government and for agencies to do these things, and it's not happening? Why is that? What's going on exactly?
So one of the things I found in reporting this was everybody who sets policy in government agreed that the problem was massive and needed to be addressed. I don't think anybody sort of realized how big it was, and it kept growing at a rate faster than they could kind of get their arms around it. So that was one problem. The other problem, despite, we have all this research, we have all this evidence that Eric talked about, there's still a reluctance among policymakers to embrace different forms of treatment. I think one of the things that I found that another state is having some success at is called the hub and spoke model for treatment. And I don't know if Eric knows much about this or not, but as I understand it, it's sort of like a centralized sort of thing here in the middle where people who come in and say, I need help, I need treatment, they're given a thorough assessment and they're directed to treatment that suits their particular story. I don't think, one size fits all is how we should approach this, and I don't think there's anybody who I mean, there's a lot of similarities between people's stories, but everybody's a little bit different. So I think a lot of times when people seek treatment, you know, they go to whatever they can find, and that may not be the best fit for them. And so I think, you know, what I found in my reporting is that there's a lot of things happening in different pockets in different places in the state, but it's a pretty fractured system, right? There's not a real clearinghouse for agencies and providers to sort of work together on it. And I think, you know, we all have different opinions about whether government is the answer or not, but I think, you know, in a public health crisis, I mean, this is an area where the government can step up and be that. And it hasn't really done it yet, and it may not happen, and maybe that's not the answer, I don't know. But I think, you know, and maybe Eric can speak to this a little bit too, because I know he had a role in a previous administration, so.
The disconnect is simply political will. When you have a recipe that works, you know, we heard it in a recent radio address from the executive branch, you know, a rainy day fund and cash on hand that has more zeros than you and I will ever have or imagine. You have sort of the perfect storm to do the right thing. And when it doesn't happen, you have to wonder why. And political will is really what it comes back to over and over and over again. Well, if we expand access to treatment, does that mean someone's going to ask to expand Medicaid? Right? That's been vetoed 3 times. How many?
5 times.
5. Maybe we'll see what happens with
6 times.
the referendum this coming year. Maybe that's the way to go, right? But then you saw the next step was we should do away with people's referendums, right? You know, ultimately, that's just about political will and finding the right relationships to leverage the change. And it's been very difficult to do that. For whatever reason, in recent year, there's this thing that happens with inertia that if you can get about 30% of a group of people moving in one direction, that energy will take everybody else the rest of the way. That's why there's, you know, about $7 million on the table right now to expand treatment, is because we kept at it, and roughly 1/3 of those voting legislators got to the point of saying, yeah, it's time. We're going to do this. And it carried everybody else the rest of the way. That's a leverageable moment and one that should be continued to be pushed on, right? What's happened is a start, but it's not enough. It's a good start, but it's not such a good start that we should be quiet about it, right? It's not, wow, thank you, we'll be quiet now.
So we have time for one more question, but I want to try to answer your question also, because I think it's the most important question of the night. And as somebody who was intimately involved with this project and my personal experience researching this, I differ a little from what they say. It's very simple. The victims are not sympathetic figures to many people. There's still the stigma. And that's why we did the project. That they're real people with 360-degree lives. And when the public realizes they're not just lowlives who, as our first person tonight implied, just stop. What's the problem? It's a disease. It's not just bad behavior. It's the stigma. That probably is the biggest reason for the disconnect, I think. One last question. Oh boy, how do I choose? She hasn't gotten it.
So first a comment, I think the series should win a Pulitzer Prize. I just want to say that. But I want to go back, Nikki, to your work in the sober house. And clearly sober houses appear to be a significant component for some people in their recovery. And for women, I think you said there are only 10 in Maine. I didn't know where. So in the short term, is there any lightening of that, any bright spot? Do we see that there'll be more creation of sober houses for women? I don't know if any of you can talk to that. I don't know what it takes to create a sober house, so.
Yeah, sober living is not like, it's a part of the bigger solution and a part of the bigger puzzle. And I think it's been spoken a lot, like there are many paths to recovery and there are many styles of recovery. And it's really contingent on each person and what works for them. But for women's sober living, like my opportunity kind of fell in my lap in a weird way, and there's not a lot of standardization around it, which allows for people with maybe the right intentions to do it, but I think there needs to be a lot of caution, and that like just anybody could do that too, and that more harm could be done than good. I mean, I've been working in the community and I got a lot of input and a lot of support from people who know what they're doing in sober living and, you know, more successful. So I wouldn't just be like, run out there rampant and create all these sober houses, but it is part of the package and solution. So I guess that would be a good way to.
I think we have to call it a night.
I just want to say, everybody who doesn't subscribe to the Maine Telegram and the Portland Press Herald, do it.